is by Dr. PARAS MEHTA, who is a distinguished cornea and ocular surface surgeon from Vadodara, Gujarat. She is talking about late visual rehabilitation in unilateral cases where other eye is normal and patient has got a chemical injury in only one eye. So she is going to talk about how to rehabilitate those patients and give them vision in ipsilateral cases. So over to you, Dr. PARAS.
Yeah, thank you, Dr. Swapnil. And I would like to thank Dr. Tuhin and for letting me fill in for Dr. Jayesh Wazirani. I would be essentially talking to you about late visual rehabilitation in unilateral ocular burn cases by different modalities of treatment. Once you have treated a patient of acute burns and you have allowed the ocular surface to stabilize well, then the area of, this rehabilitation would come, because you have to take care of their visual needs and the other areas. We all know that limbal stem cells are responsible for the regeneration of the corneal epithelium and maintenance of the integrity and transparency of the cornea. Destruction of these limbal stem cells and the stem cell niche or both leads to limbal stem cell dysfunction and deficiency. Limbal stem cell deficiency in itself results in delayed epithelial wound healing, recurrent epithelial erosions, and loss of vision. So these are various clinical pictures of limbal stem cell deficiency, which is characterized by conjunctivalization of the cornea or pannus formation, recurrent epithelial breakdown and in turn inflammation of the ocular surface, and loss of transparency of the cornea leading to impaired vision in these cases. There are various causes of limbal stem cell deficiency, but here our IC is related to ocular burns. I would like to share this reference of various causes of limbal stem cell deficiency, especially unilateral cases, wherein one of the studies showed that almost 84% of the cases were contributed by ocular surface burns, and we are concentrating on that area. While in bilateral injuries, it was almost 1/3 kind of distribution. Corneal transplantation alone is ineffective in limbal stem cell deficiency as it results in recurrent epithelial breakdowns, surface healing issues, and ultimately graft failure. So fortunately, we are very fortunate that limbal stem cell transplant can restore the normal epithelial phenotype and can re-establish a stable corneal surface. Here I won't go into the detail of epithelial healing, but we all know that the limbal stem cells reside at the limbus and into the limbal niche and crypt, and from here there could be asymmetric and symmetric division, and it can take care of the whole epithelial surface. In patients with unilateral limbal stem cell deficiency, the healthy fellow eye can serve as a donor cornea, donor limbal tissue, which makes the procedure autologous and obviates the need for any systemic immunosuppression. These are clinical examples of limbal stem cell deficiency following chemical injuries. You can see that the first picture on your left hand side shows almost partial limbal stem cell deficiency, almost 180 degree with pseudo-pterygium, or you can say a pannus extending onto the cornea. The second picture shows there is, even in addition to pannus, there is a lot of corneal scarring into the central area, patchy scarring, and the third shows almost 360 degree limbal stem cell deficiency leading to total conjunctivalization of the cornea, and the cornea is totally obscured with the conjunctiva. So, but this healing is also good. I would say that if you reach to this end result in an acute burns, it is a good achievement. Once you have reached to this level, you can definitely do lot of, reconstruction for these cases. Here I would like to share an algorithm for management of LSCD, limbal stem cell deficiency. Essentially, before you go on to embark onto management of limbal stem cell deficiency, you would like to control the inflammation onto the ocular surface, which could be in the form of medical management and later on surgical involvement. Here I have highlighted two squares in terms of when we are dealing with unilateral limbal stem cell deficiency. There are various modalities available. One of them is conjunctival limbal autograft, SLET and CLET. We would go about it in detail. So techniques of limbal transplantation has evolved over the last 3 decades, and fortunately enough, all of them are still, currently in practice. I would talk about conjunctival limbal autologous transplantation, which was popularized by Kenyon and Seng way back in 1989. Essentially, what they did was the procedure included obtaining 2 grafts of 2 clock hours each from the limbus, and the adjacent rim of conjunctiva was taken from the patient's healthy eye, and especially superior and inferior limbus. And this procedure has the longest track, and this is implanted onto the affected eye after removing the PARAS and all, as you can see here in the pictures or schematics. This procedure has the longest track record so far and has been shown to successfully restore the corneal epithelium in approximately 75% of the cases. But later on, a lot of other researchers did, research, and they realized that, it is not possible to restore a full cornea with 360-degree limbal stem cell deficiency with just one technique. Then, the concept of, cultivated limbal epithelial stem cell came. Dr. Pellegrini and group popularized this technique, wherein in 1997 they described cultivated limbal epithelial transplantation, where a 2 by 2 millimeter small piece of limbal biopsy was taken from the donor eye, which is expanded ex vivo in the laboratory for 10 to 14 days into a sheet of epithelial cells, and then it is transplanted onto the surface of the affected eye. That means you just call the patient for first, taking the limbal biopsy, and then after expanding that limbal biopsy into laboratory, you again call the patient for, transplantation of these cultivated limbal stem cells. So that required 2-stage procedure, plus you need culture facilities and lot of regulatory, things are required. So that is a very expensive thing, and probably it is within the armamentarium of institutional practice. The third technique, which was, this was Dr. Virendra Sangwan and group described in 2011-12, came up with a novel idea of simple limbal epithelial transplantation, wherein they used, especially in unilateral limbal stem cell deficiency. And they, a strip of donor limbal tissue from the superior limbus was taken, similar to cleft. And that was, transplanted onto the healthy eye, but here instead of ex vivo expansion, it was divided into small pieces, and these explants were transplanted directly onto the affected cornea for in vivo expansion over human amniotic membrane graft along with fibrin glue. So that works as a scaffold for these, cells. So these are the steps of SLAT in, the pictures is showing different steps of SLAT procedure. Later on, certain modifications were described, like customized SLAT, where, if there is a more area of involvement, the limbal explants were put into those areas. Even some researchers described sandwich technique, wherein another amniotic membrane was covered on top of the explanted limbal stem cells, and it was also combined with conjunctival autograft and combined with mucous membrane grafts. Looking at the results, a lot of researchers came up with, multi-central studies, and the results were very encouraging. As you can see here, they compared, autologous limbal stem cell transplantation with cleft and SLAT. Especially autologous limbal stem cell transplantation for unilateral limbal stem cell deficiency showed anatomical and functional success rate of almost 69% and 60% respectively, without any serious adverse events in the donor eye. While the anatomical and functional success rates of SLAT, that is simple limbal epithelial transplantation, was 78% and 68.6%, and conjunctival limbal autologous transplant was 81% and 74.4%. They were comparable and significantly better than those of cleft, which was little lower, as you can see here in this bar diagram as well. People also compared, cost of cultivated limbal epithelial transplant and simple limbal epithelial transplant, and it turned out to be the results of economic analysis suggested that SLAT provide an estimated cost savings of almost US $6470.88 for adults and 6673.10 for children. In broad term, if we translate that, the cost of SLAT is approximately 10% of the cost of cleft for adults and 8% for the children. So let's look at the technique. Here is a video of showing how simple limbal epithelial transplantation is done. This patient had a acid injury and had undergone tenonplasty twice. You can see here I'm taking, 2 conjunctival grafts from the donor eye, and here I'm dissecting the limbus to obtain, small 1 clock hour of limbal tissue, which can be splitted into 8 to 12 pieces. and transplanted onto the affected eye in, small pieces. The donor eye is covered, so now we are working on the recipient eye. After dissecting the pannus, both the, conjunctival autografts are applied onto the superior and inferior limbus so that there is no, it works as a barrier. It does not allow, symblepharon formation or pseudopterygium formation. Then an amniotic membrane is applied onto the entire corneal surface, which works as a scaffold for these, transplanted cells. Once that is applied, the limbus which was, harvested is cut into small pieces. Approximately 8 to 12 pieces are enough to take care of both the surface epithelium as well as the limbal niche in these cases. This is fixed with the help of fibrin glue, and a bandage contact lens is applied, and in some cases we also do a tarsography at the conclusion of this surgery. You can see here the same patient pre-operatively and post-operatively in these clinical pictures. He was a 28-year-old male who sustained Lyme paste injury. He underwent tenonplasty and amniotic membrane transplant twice elsewhere before he was referred to us. And as you can see here in clinical picture on your left-hand side, he had very severe symblepharon, almost involving the lid being attached to the limbus, inferior lid, and a lot of pannus covering almost the entire, 360 degree of corneal limbus, except a small patch of, 1 claw cover of limbus here. So this was the post-op result, post, limbal epithelial transplant. This is another case where, a 10-year-old male child sustained Lyme paste injury, post-symblepharon, and these are the clinical pictures post-symblepharon release with pannus resection and conjunctivo-limbal autograft. Here we decided to take a conjunctivo-limbal autograft because the area involved was much less, so it did not need, slat procedure. This is another example where 180 degree of, limbus is covered with pannus. So we decided to have, slat with conjunctival autograft, and you can see the results post-operatively. This was a 23-year-old female with unilateral acid injury, underwent autologous slat from a fellow eye, and best corrected visual acuity improved from 6 CFCF counting finger close to face to 6/9. You can see a dramatic results of these procedures here. Here is a 45-year-old male who sustained, injury with a disinfectant powder almost 30 years back. And that eye was not it was partially amblyopic, but he was, presenting with recurrent surface breakdowns and inflammation, as you can see here into the clinical pictures. He underwent slat and conjunctival autograft, and this is how his surface looks, and the eye has become quiet eventually. This is 32-year-old male who sustained splash of liquid ammonium chloride 18 years prior to presentation. He underwent some pseudopterygium surgery elsewhere, and he had again, pannus formation. So we had to take him for slat, and he underwent conjunctival autograft. Horizontally, you can see two grafts on both the sides, and underwent a slat, and you can see that the eye has become quiet and his vision improved from 624 part to 612. So you can have fantastic results post this procedure. To summarize, techniques of limbal transplantation have evolved greatly over past few decades. Slat combines the advantages of both conjunctival limbal autograft and cultivated limbal epithelial transplant. It is a simple, inexpensive, and single-stage procedure. Anatomical and functional success rates are equal or sometimes higher with slat compared to conjunctival limbal autograft and clot. The costs are significantly lower with slat compared to clot, making it the technique of choice for limbal transplantation almost globally. In the setting of bilateral limbal stem cell deficiency, allogenic slat is a potential option, but that will require long-term systemic immunosuppression, which is not needed in unilateral injuries. Thank you for your kind attention, and thank you for the opportunity.
Okay, Dr. PARAS, nice, excellent presentation.